Chapter 8, Body Mechanics and Patient Mobility. What does body mechanics mean? How you use your body. Okay, proper body mechanics can prevent you from getting hurt. And we're going to talk about that. And patient mobility, let's say they're mobile, they're ad lib, or they're immobile, they're total care, right? And we're going to talk about how that affects them physically, but also mentally and emotionally, okay? Body mechanics have to be learned by nursing personnel to prevent injury. Guess who has the #1 rate of of back injuries? Nurses. We in the medical field are lifting people when they're dead weight over and over and over again, every day for 12 hours. So you are high risk for back injury or hurting something else in your body. So that's why they make you go through body mechanics class, okay? And it's super important to do it because I was young one time like y'all and had a great back. Now I don't because I did not practice my mechanics. I thought, one time won't hurt. And I blew disc after disc after disc. So it's serious. Take it seriously. You don't want to hurt yourself because then you end up with a life of pain. Okay? Evidence-based practice, we talked about that a little bit at the very beginning. Evidence-based is kind of like what Florence Nightingale did. She had all that information, the evidence, and then they made a policy or procedure out of that was evidence-based. And that's how they came up with the best way to lift patients. We bend with our knees and our hips. Go straight up. We don't bend over and strain our back because our body's not made for that. So they came up with other things that were specific for nurses. Raising the bed up to a comfortable height for any task. You think, I'm just going in there for an IV. I don't have to, lift them. But you're bent over in a really awkward position. It doesn't take much to tweak your back. And so then you've got a pinched nerve and leads to more problems. So every little thing matters when you're applying it in nursing. They came up with other equipment too. What's something that we use to lift patients with a machine? Hoyer lifts. They are a lifesaver, aren't they? They're a pain in the butt to get in and out of the room, but man, they're better than do it yourself. Okay? Reasons that we worry about mobility for patients, like their ability to move themselves or not move themselves, is obviously they have fragile skin. We already talked about skin in our other class. It thins as we age, and you lose that adipose tissue, that cushion, so they're higher risk for skin tears, wounds, things like that. So we support the joints when we move them in the bed because we don't want, them to have pressure points. They lose their flexibility and their joint mobility. It's very easy to pull somebody's hip out of socket when they're an elderly because they don't have that muscle tone anymore that holds all of our bones in place. And so they're just flaccid and it'll flop over and then they've got a dislocated hip. Not even from falling. We moved them improperly. Weakness, they're tired, they're fatigued, they don't have any muscle strength. They may have that orthostatic hypotension where their blood pressure drops when they move around. And also they have an altered sensory perception. A lot of them are either have trouble seeing, hearing, or cognitively they're not able to understand what you're telling them. They have a processing delay. So that can be something that you tell them, most people, they know when they need to get up and go to the bathroom, they get up and go. Well, if you're cognitively delayed or you don't feel that sensation, what happens? You void on yourself, and then you've got risk for skin issues because they couldn't remember to get up and go to the bathroom, or they're unable to go completely without assistance. Proper body mechanics is for the large muscle groups. When we talk about lifting, we use our leg muscles, our quads, and our gluteus max, our glutes, and our abs. Those are our large muscle groups. Think about, any of y'all ever run track in high school? Remember how good your legs were in shape then? Ooh, those strong muscle groups. You could just run. Those are the muscles that you need to use. That's what they're meant for, is for leverage, for lifting. That's how we are designed. And so you use those rather than the little bit of the muscles that are in your back. Those are meant to just keep us straight. They're not meant for lots of weight. So you want to use your large group muscles, okay? Tuck in your stomach, get a wide stance, and lift with your legs and your butt. That's proper mechanics. The area of physiology that studies muscle action and how muscles function in maintaining the posture of the body and preventing injury during activity. That is the definition of body mechanics. A lot of people spend a lot of time trying to figure out how to save us and prevent us from getting injured. So body mechanics in health care is a huge, huge deal. And you'll have to go through training after training after training. Any of y'all have to wear a belt, back brace belt?
Oh, no.
Do you wear it and just leave it open? Or do you actually put it on and Velcro it?
I don't have to do that. I just don't know you take that.
Well, those are for, for patients. But for your own personal back injury prevention, a lot of places make you use those. It's to help you stay aligned. It's to help you not twist when you're lifting somebody, or you just turn and you can feel it the second it happens. And it's like, oh, then 8 hours later you can hardly move because it has swollen now. Okay? Always have a wide base. It means your legs or your feet are as wide as your shoulders. You're going to bend with your knees and use your leg muscles and your hips and all to lift straight up. Never using your back. Okay, mobility, as far as from a patient standpoint, or any of us really, but for a patient, think about that's the ability to move around freely. We can all get up and go and do whatever we want, can't we? How nice is that? Think about if you couldn't. Let's say you've had an injury, a stroke, or an amputation, or you've just got cognitive, delay, and you can't get up and move. Your body doesn't work anymore. How trapped would you feel? How trapped inside your own body? You cannot even get up to go get a glass of water that you want so desperately. You can't even reach over and get tissue to wipe your own nose. So mobility is a huge deal for patients, or lack of mobility if they can't do it. The purpose of mobility is to help us exercise, keep our muscles limber and fit. Expressing emotions. Let's say you're excited and you want to go over and join that group as the patient. You're excited, they're having music time, you want to go over there, but your legs don't work. So they forgot about you and you're just sitting here watching it all happen. How sad is that? You can't express your emotion or feeling that, oh, I want to be included. I want to be part of the group. Same with, let's say you're depressed. You're the patient and you found out your roommate just passed away through the night. You don't want to stay at the breakfast table. You want to go back to your room and just lay in the bed and cry and mourn her, but you can't. You have to wait on someone to physically move you back. They are unable to express their emotions. They have zero control, mobility-wise. How awful would that be? Your basic needs are not even met. You cannot get water. You cannot feed yourself. You can't go to the bathroom by yourself because your mobility is limited. So that's a very, very important thing as far as when we talk about patients' rights, why that's a big deal. Think about it from your standpoint. How would you feel? I wouldn't be able to handle it. Other things that can be affected by mobility, recreational activities. You know how they like to get in groups and do the little exercises. If they can't do that, that kind of makes them withdrawn. They get depressed and they isolate themselves because they give up. And then just basic ideals, like we said, feeding themselves, grooming themselves, going to the bathroom. ADL is activities of daily living, if you don't know that term yet. That just means things that we do on a daily basis, like feeding ourselves, bathroom, dressing ourselves, walking when we choose to walk. Activities of daily life that we live in. Okay, so when you have mobility, you're pretty much free. Think about when you're immobile. We talked about that. Some of the complications of being immobile, where you cannot move on your own, your muscles start to atrophy. What does atrophy mean? They break down or wither away. What about contractures? Y'all heard that term yet? Yeah, limited range of motion. Those joints kind of freeze up, and so they're not able to stretch and extend it completely or utilize it because there's a contraction in there, or their hands are just clamped. They cannot open their hand at all to do anything. That's a contracture. What about osteoporosis? You ever heard of that one? That's where their bones are just like porous. Yeah, they're just like a. Have any of y'all ever seen a lava rock that you use to scrub your feet with or limestone? That's what their bones actually look like because they're not full of calcium anymore. usually don't go good. Pressure ulcers, that's another risk of being immobile. We kind of talked about that when we did skin. If you stay in the same position for hours on end because you aren't able to talk, so nobody comes and helps you. You're that quiet patient, and they just think, oh, Miss Robertson can sit there for another hour. I got this one over here is fussing. I gotta go take care of her. Miss Robertson can sit there another hour. It's almost lunchtime. Miss Robertson, she don't ever take a nap. She can just stay over there. She likes watching TV. How do you know? I can't tell you that. But you're assuming that I like to sit there. So guess what? I sat there for 8 hours and now I have a pressure ulcer. Because no one moves. Constipation, same thing. When you're not able to move around, your bowels are muscle. So they are locked up too. When you're not able to walk and move around, that's peristalsis. That's the muscles that are in your bowels. That's the act of them moving. And so if they're not moving, then your bowels lock up. You become constipated, which we know in elderly that's a real bad common thing that happens for them, and it's hard to correct it. They don't eat enough, they don't drink enough, they don't move enough. So once they get constipated, it can become an impaction. Those are very difficult to get out. Sometimes it can be a bowel perforation if it's bad enough. Their bowel can actually burst, and then they become septic and die. All because no one wanted to move them, and they couldn't move themselves. You can also get pneumonia. We talked about that. When you sit still and you don't take good deep breaths, all that fluid's going to build up in your lungs, and that becomes pneumonia. So those are terrible things to happen to you, and simply because you cannot move your own body, isn't it? Some of them can kill you. Some of the assistive devices that they use when you're talking about mobility and helping patients, we use pillows to prop up those bony prominences, right? We'll put them under their elbows, maybe under their hip, under their knees, under their heels of their feet. They can have the foot booties. They look like the inside of an Ugg boot, a little sheepskin. They Velcro over, and those are just an extra little pad. Because again, they've lost all of their natural padding, so it's skin on top of a bone. And there's nothing there to keep it from eroding. And so that's where they get those pressure ulcers from. So we try to put the booties on to give them little cushions. Trochanter rolls, do y'all know what those are? Trochanter is one of your leg, in your hip on the bones. This long one here, and so they'll put, it's almost like a sandbag. It's real heavy, and they put it right there to prevent their legs from rolling out. So if you're laying in the bed relaxed, everybody's feet just kind of turn out naturally, and your hip rotates out. Sometimes they don't need to. They want to keep them straight in a line, so they'll put trochanter rolls on either side of their legs to keep them straight, to keep them from laying out, because then that's stressing those hip flexors too much. And sandbags, kind of the same thing. They can use those to position. They stay in place better than a pillow. And then a trapeze bar. Does everybody know what a trapeze bar is? The little triangle that hangs over the bed, and they use it to help pull themselves up if they can. So those are devices that we can use even if they're immobile. Sometimes those can help, okay? You need to be familiar with them. All right, here's your first question. Can you see? One, two, three for sure. I would even pick fever if you wanted to overthink it too, because what happens when you get pneumonia? What happens if your pressure ulcer gets affected? Yeah. So yeah, any of that really. So is having pneumonia fun? No. What about a pressure ulcer? Can't be. Gotta be painful. What about having an embolus? That's a blood clot that goes to your heart or lungs. Kind of could be fatal. So not fun for that either. Can all of that be prevented?
Yes.
Yes, it can. Okay. And that's where nurses come in, nursing assistants and our team nursing. We all want to make sure that we keep that patient from getting all of those complications. This gets too much. Okay, so remember when we did our other positions, our medical terms that were directional terms? These are some more, and they just apply to positions positioning of the whole body. And I have y'all some handouts I'll give you in a little bit. So when you are talking about, remember we said anatomical position is just where I'm standing facing forward, right? Like this, and the palms forward. And on page 161, there's a good picture of the center of gravity. Just everybody's center, kind of right there at the navel almost. That's where everybody's balance and stuff comes from. If your center of gravity is thrown off, then more likely you're going to have a higher risk for falls. Okay. That's a question. Okay.
This picture is on our good book.
It should be. You mean this chapter of the slide? Should be. I can put every one of them on there. If it's not, that would be. Okay, so on page 163, there's some pictures. And this is probably like you're talking about for your next class. Probably good to look over. When you want to put a patient in the dorsal position, we already know what dorsal means. What does that mean?
Back.
Our back. So they're going to be lying on their back. That can also be called supine. Most of the time you hear they're in the supine position, and that just means lying flat on their back. And there's a picture of it on page 163. A lot of patients lay like that for surgery. A lot of them to sleep. If they don't have any kind of stomach issues, heart issues, or breathing issues, they want to lay flat. Okay. Dorsal recumbent is laying on your back with your head and your shoulders and extremities moderately flexed. So that could be like, there's a picture of it. Oh, maybe there isn't a picture of this one. So like if you're just laying on the bed and you're relaxed, everything is rolling and flexed. Like you're not straight. Your elbows are flexed a little bit and your knees are flexed a little. You're just relaxed. Okay. These two are real important, semi-Fowlers and Fowlers. When you're having any kind of respiratory or cardiac issues, you need to be in high Fowler or at least, the very least, semi-Fowlers. Okay? The difference is the height. Semi-Fowlers is 30 degrees and of the head of the bed. Then you can roll their head of the bed up. And Fowlers is 45 to 60. So it's almost like almost straight up. Why do you think that would matter if I was having trouble breathing? What would it matter if I had, let's say, GERD, or where I'm having stuff come back up? Gravity's going to help pull it down. What if I had swallowing problems? Why would I have to be up at high Fowlers when you feed me? Aspiration risk. If I don't swallow good, chances are I can choke and some of that's going to go down my airway instead of my esophagus where food and water are supposed to go. And then what sets up if you aspirate? Pneumonia. So those are real important to always have our patient in the proper position for whatever procedure we're doing. And you'll learn more about that. This afternoon we'll go in the lab and we're going to practice doing those. Okay. Orthopneic is one, and there's a picture of it on page 164. That's where your patient is sitting up on the side of the bed, and you can give them a pillow or something to put on their bedside table, and they kind of are leaning forward. Sometimes they use this. It's like if they're having real trouble breathing, or if you're doing chest percussion on their back, trying to break up a lot of congestion, or if they're having some kind of procedure, sometimes the doctor will want them in the orthopneic position. So you kind of need to know what that is in case you ever hear it. Because if they tell you to go put them in the orthopneic position and you look at them like you're talking another language, they're going to get mad. Because usually if they want them in that position, they're really sick. So they need, the time is of the essence. Okay, Sims position is lying on your side with the knee and the thigh drawn towards the chest. Usually on your left side. What do we do when we're laying somebody on their belly or on their chest and their knees drawn up? Enema. Yep. Left side lying with your knee to your chest is Sims position, and that is what we use when we're giving them an enema. Why do they have to be on the left side for an enema? So and we'll talk about this when we get to your GI Here's your small intestines, all the foods come through here. It starts in the ascending colon, transverse colon, descending, and then the rectum where the stool actually comes out. And so this is on the left side, right? This is my patient's left. So they need to be laying on the left side if you roll them over because the water will go in that bowel, sit there, and then pull the stool out. If they're laying on the right side, this is on top. And water's not going to run in there. It's important because of anatomical position. We need to be on the left side for Sims position if they're doing an interval. Okay? And then prone position is just lying face down. Some surgeries you have to be prone position. Back surgery. Some do bladder repair surgeries in this position. You're pretty much splayed open and they are they have you spread out and everybody's seeing all your business because that's anatomically the best way they can get to that part of your body. So I think a prone is like you're more prone for your privacy being invaded. That's how I remember that. And supine is just lying on your back looking up at pine trees. You remember them that way. Or memorize it. Makes too much sense to memorize. Okay? Any questions on any of those so far? There's pictures of them, most of them in your book. Okay, this is fixing to be a fun one. Woohoo! Okay, there's a picture on 165. I'm just gonna let you look at the picture. Visualize that. I don't want to hear any personal stories about that situation that you've been in or that position. Just know that you're on your hands and your knees and your abdomen is raised and your head is turned to one side. This is another one that they may be doing an examination on you. Okay?
I think they're doing more than exam.
Maybe. I don't know. But just know that's what that one is genitopectoral. And that's just so that you can get up, they can anatomically examine you. Okay, and then the lithotomy position. Anybody ever had pap smear?
Yes.
We're all too familiar with this one, aren't we?
Yes.
Lithotomy position, if you've had the pap smear babies, that is how they put you get to scoot your bottom to the very end of the table, and I mean the very end. Cheeks are hanging off. And you as a nurse have to go in there and tell them that. Okay, hon, I need you to, lay back on the table. I'm going to put your, stirrups out, and you have to put your feet in these stirrups. And they're like, okay. And you go in, and they're way down here. And you're like, I need you to scoot down. I need you to scoot down. Keep scooting. Keep scooting. I'm about to fall off. Keep scooting. Come on. Okay. Because you literally have to be on the edge because when the doctor examines them with the equipment, the table cannot be in the way. He has to go in with the equipment at a certain angle. And if they're not off the table, practically, the equipment won't work. So just know for lithotomy positions, if you're going to work OB, GYN, that's your thing. Wasn't mine, but if you like that kind of thing, that's the position you need to put them in. And you're going to have to be the nurse that reassures your patient, come on, and be nice. And then they're all timid and trying to keep their knees together now. Like, come on. You were shy 9 months ago, come on. So, just know that that's the position for that one, okay, for pelvic exams, okay? And always provide privacy. You want to, keep them from being exposed. That's a real big thing, a patient's right. You want to provide privacy and keep them from being exposed because they are embarrassed and shy. I mean, they're not nurses. They're not used to showing their body to everybody, and it's their body. To us, it's just another patient, another, hoo-nanny that we've already seen a million of today. But to them, that's their hoo-nanny, and they don't want to show you. So you have to provide privacy, okay? All right. What did he just say? What's a hoo-nanny? Marcus. Let me down. The ladies' private area. I can give you the medical terms.
I was looking for it.
That's going to be our next bonus question. What is a hoo-nanny?
What is
Even Joseph knew that. Come on, Marcus.
Marcus, how old are you? You had never heard of that. So just know, like I said, you want to put them in the lithotomy position now. Okay, and then Trendelenburg, this is one you might want to know for sure too. It's on page 165. It's not the patient in the bed, but it's the actual bed itself. You have to flip them down into Trendelenburg. The head's down, and the legs are up. And this is more for emergency situations. Why would I need ever for my patient to be in that
When
position?
they have big stingray, you put them in reverse to Gilbert to get all that blood flow back.
Their blood pressure's dropping, their heart rate's dropping, maybe they're becoming kind of fuzzy, unconscious, something's happened. And I don't mean like an injury, just they were sitting there talking to you and all of a sudden their blood pressure's dropping. You flip them into Trendelenburg. What it does is gravity pulls all the blood from their legs back down towards the core. And that helps increase their blood pressure in their heart, the pressure in their heart, which increases their blood pressure. And it gets it back to their head so that they can become a little more coherent.
But usually they have them up in the bed.
Yeah, that does help, but you gotta make sure to put them back too, because you don't forget. Or leave them that way. And a lot of times in surgery, I would think they would put them in that position too, in case their blood pressure dropping from anesthesia. They've got them too sedated, their blood pressure dropping.
Just to like visualize, like to get some.
Yeah, to get in there deep.
Organs that's gonna go with the head.
So it's just another position. Just know that Trendelenburg is usually used if their blood pressure dropping for more emergency support, like maybe in surgery to visualize the anatomy a little bit better. As if being in the other ones don't show everything else you got, but. Okay, what do y'all think about this one? Everybody know what an NG tube is? The tube's going through their nose, down into their stomach. We use that to, if their stomach's got a blockage or something, we pull all the secretions out, or if they overdosed, you can pump their stomach with one of those. You can also put feedings in through an NG tube. Like, let's say they're having trouble swallowing, so we're going to put a tube in and see if they can tolerate milk. So while they're in the bed, what position do they need to be in? High Fowlers. We don't want them laid back and it'll go down the wrong pipe. Okay. Oh, and there's one more. Do you know what lateral position means? Yeah, on your side. Good. We just learned that term. How far did y'all's reading go? I don't know if 4 parts are past
183.
So just look through those pictures for your test, your quiz this afternoon. Somebody was asking earlier about it. I would just look through those and kind of know those terms. There's a good picture of a trapeze bar. The lady's helping her, and see how the nurse is scooping under her hips to help her go through. We know these trochanter rolls to keep their legs from rotating out, or you can use like as a draw sheet to pull them up with also.
And the trochanter rolls, you can use towels, right?
Mm-hmm. Also, yeah, just to keep that trochanter when you're talking about assessing a patient, we talked a little bit about their neuro function, and we talked about capillary refill. Does anybody know what capillary refill is?
The amount of time it takes for your to get pink again.
Everybody squeeze their fingertip. Squeeze it, really, like blanch it so that it's blanching out white. Squeeze it pretty tight, and then you let go and watch it. Did the color come back in it? So that's your capillary refill. There's capillaries, or little tiny blood vessels under your nail beds, and you're pinching it off just like we do with our blood pressure cuff. You're blocking the circulation for a minute, and when you let go, it circulates back through.
What if someone now is still white from
You're probably anemic. We need to check your mucous membranes later. So that's part of your assessment. For one, you're checking for circulation, and two, for neuro, just to help to make sure you'll pinch them and see. And you'll say brisk capillary refill, or slow capillary refill, or pale nail beds noted, things like that. All right. You always check the skin color and the temperature of the skin. You're watching for movement and sensation. There's little things like they do for diabetics that it's like a little filament that you can tickle the bottom of their foot with to see if they feel that. If they feel it, that means they've got circulation or good feeling. If they don't feel it, they're probably starting to get a little bit of diabetic neuropathy. So just
they be real crusty, like I'm talking about
they need to go to foot clinic.
I get it
side down.
You can, yeah, or you can use, the arch of their foot where it's not been touching the ground. That arch sometimes is a lot softer skin, and you can try it there, or in between the toes. If you hadn't killed them already, like Sable's trying to do back there, killing people sticking air between their toes. Y'all stay away from her. Just saying. All right, so just know those are kind of some of your things that you want to watch for too when you're doing these type of things with your patient when you're moving around. Anybody ever heard of compartmental syndrome? Everybody heard of skinny jeans? I can't wear skinny jeans because they cut off my circulation. They have compartmental syndrome. My calves are too big, and those things just start compressing, and it's like, Lord, I can't breathe, I can't walk, I can't do anything, and then my legs go numb from stupid skinny jeans. So I don't wear skinny jeans. I don't know how these girls do it. So just know that it can be from anything. They could have too tight of clothing. It could be, something that's constricting them. Maybe the family brought some clothes that are too tight, or they wanted them to wear these certain kind of shoes. It could be anything.
So
It could be the blood pressure cuff.
is it just one area?
It's compartment meaning one area at a time, and then it just starts getting pain because it's being compressed. They start getting that tingling feeling, like those pins and needles, and it hurts, and then eventually it gets numb, and they have partial paralysis there from it. Sometimes that can also happen if they've done repetitive movements during exercise. Have you ever had to type a lot, or you've done a job where you're doing the same movement over and over again, you get carpal tunnel? It's kind of the same situation, same symptoms.
My mom had a tibia fracture in her leg.
And the cast.
Yeah, and it swelled so much she had to do a raised fasciitis on both sides of her leg.
Yeah, the cast, glad you told me that. That's a big one, I forgot. A cast, like if you have a patient with cast and they're saying, I'm having numbness and tingling, I can't feel my toes, and you do a wrist cap refill, and there is no cap refill, chances are that it has swollen inside that cast, and now they aren't getting any circulation, so they have to cut the cast off and cut the skin because there's so much fluid there that it's pressing against the nerves. That's what compartmental syndrome is.
They just leave it open.
Yeah, they have to leave it open, give it a big long cut. Yes, ma'am. Do what? Sometimes they put you in cock-up wrist splints. They make your wrist do this and hyperextend it, and so that's supposed to help take the pressure off of that. And then they can do physical therapy or OT where they teach you how to rotate and do different exercises that's supposed to take pressure off of it. Obviously, you have to stop doing the same thing you were doing because that's the cause. Yeah, they can do that. There was a lady where I grew up. There's a big chicken plant there. Everybody raised chickens, and then they sold them for Tyson Foods for chicken. And that was her job, was to cut open the chickens. And she did the same repetitive movement every day, cutting through that hard, cartilage and stuff. And so she had a carpal tunnel bad, and it was radiating all into her. It was very painful. It felt like somebody was squeezing her arm all the time, real tingly and numb. And we tried the wrist splints, we tried OT, PT, and eventually she had to have surgery where they go in and they release that, whatever is triggering it, with what's pressing on it.
Did she feel better?
Yeah, she did. So that's another thing, you'll see a scar on their wrist. You can ask them have they had carpal tunnel surgery, and they'll let you know, yeah. So just know that's part of compartmental syndrome, that the numbness and tingling. Okay. All right, let's take a break, and when we come back, we'll talk about range of motion exercises. We'll do some fun stuff.
I was sleeping good this morning,
Ma'am?
and I went to stretch. I got charged with somebody.
Did you? You need your sister to rub it out.
It was so bad.
Where is it? Your calf? You might need to eat a banana or something. Get some orange juice.
It makes my mouth feel all.
Yeah, you can do, they have, let's see, what is it, that smoothies, you like banana smoothies? Try that, or something that's strawberry to take that taste out, but give some potassium, that's what's causing the cramp. Low on potassium.
What about like vitamins?
You can do potassium, supplements, but, orange juice has a lot of vitamins, or potassium in it.
Are you super busy this morning?
Since we're twinning.
I know, right?
Okay, twin,
See,
what
I
do you
tried to
mean?
put my shoulder up there. I don't know if
Are you trying to lock yourself out?
They just left, so probably another 10 minutes. They just started. Thank you. Okay, so y'all are gonna have a, person can talk to y'all, women protective services, so while she's here talking to y'all for 30 minutes, I'll go for it.
Where? Oh,
Women's protective services.
Wait, what would I miss?
She just said that there's a lady coming to speak to y'all this morning that she thought she was coming on Thursday, but she showed up today. So that's what I said, while she's here, I'll go for y'all's test. Huh? She said, no. Crystal, you crack me up, girl. With your sweet little smile.
I hear you in my head all the time. Okay, you may not have it. This is her.
Oh, wow, yeah.
Surgery and then their infection.
Okay.
She had
legs.
How
How did she break it to begin with?
No, she was trying to move TV and it was too big and it fell over on her.
Ugh. More body mechanics. Ended up in a 6-month.
Oh, no, I know.
Miss Dawn, one of my childhood memories is my aunt, she used to work at EXO. And so she had carpal tunnel, and she had surgery on both hands at the same time.
Oh my gosh.
And I remember I was little, and my mom was mad because she was like, why the hell she had it done on both her hands? So my
You can't do anything. You're like this. You're like a vampire.
She was,
Your
and then
wrists
we
are
made
no
him
wise.
run out the door, she had locked it, and my mom was
It is painful. I got carpal tunnel when I was pregnant. Like 9 months pregnant, all the fluid in my body from my baby was just pressing down on that nerve. And I mean, I would wake up like my hands are.
We're now
more
more
sleep, but they sting.
I have to sleep with braces on my wrist at night because I'm doing hair for so long. Oh my God, my hands hurt. Oh.
Yes, because you're doing the same repetitive movement.
And then she broke her wrist. Because she was trying to move.
Oh, stop.
What?
No, my mom.
Let me see. Yeah, 8:30 to 11:30. You what? That's just the way your structure is. Like if you're laying your foot and then if you are bad about bow leg or you walk a different way or bad shoes, just from walking incorrectly on your step, it can stretch all that underneath and I prepare special braces. Yeah, it hurts too.
It's kind of like waking up in the morning and you go to step down and you fall on your face.
Yeah, it's very painful, and they can release that passion too, and make it, somewhat a little bit better, but I don't think it ever gets completely better. 8:30 to 11:30 today. What?
Make it
Are you
cool.
freezing?
I know.
Oh my God. See, I always do that.
Are they trying to?
You ever look at old pictures of yourself and you're like, oh my gosh, I look so fat.
Yes.
Oh, it's so cute.
I do that and think I wish I still had that skin and that body.
Right?
Like what happens? Nature's cruel joke. small contact fluid. I'm just gonna turn this